Welcome back to the deep dive. Today, we're embarking on a truly, well, a fascinating journey into the body's ultimate command center. Unit 4, the neurologic system.
Yeah, it's a system of incredible complexity, constantly adapting, constantly communicating.
Right. And our focus today, using Understanding Pathophysiology 7th edition as our guide, is to really unpack its normal function first, and then look at, the different ways things can go wrong.
Which is the core of pathophysiology, exactly.
And for you listening, our goal is simple. Give you a clear path through this dense material. We'll hit the key concepts, the mechanisms, the clinical stuff, and try to connect the dots between the chapters. If there are diagrams or tables in your text, we'll describe them so you can picture what's going on.
Let's dive in.
Okay, let's start with Chapter 14, Foundations of the Nervous System, the wiring and control center. First up, the big picture. CNS versus PNS.
Right. So the central nervous system, CNS, that's your brain and spinal cord, safe inside bone.
The protected core.
Exactly. And then the peripheral nervous system, PNS, that's all the nerves branching out. Cranial nerves, spinal nerves, reaching everywhere else.
And functionally, there are different pathways.
Yeah, think of it like a two-way street. You've got afferent pathways carrying sensory info towards the CNS.
Like, ouch, that's sharp.
Precisely. And then efferent pathways carrying motor commands away from the CNS, telling muscles what to do, like move your hand.
Okay, so how does that information actually, travel? That's the neuron, right?
Neuron, yep, the fundamental unit. You can picture it like a little tree, the cell body, dendrites like branches, receiving signals.
Receiving, okay.
And then a long axon, like the trunk, sending signals away.
Yeah.
And many axons have this really important fatty coating, the myelin sheath.
Ah, the insulation.
Exactly. It's lipid material. It dramatically speeds up the nerve impulse. It's not continuous, though. In the CNS, oligodendrocytes make it. In the PNS, Schwann cells do.
And there are gaps.
Nodes of Ranvier, little gaps along the axon. They're crucial for nutrient exchange, but also for making the impulse jump node to node, super fast, super efficient.
Wow. And you mentioned the brain can change. Neuroplasticity.
Oh, absolutely. Neuroplasticity. It's the brain's amazing ability, lifelong, to reorganize itself, form new connections. That's how we learn, adapt, even recover from some types of damage. It's fundamental.
Okay, that's incredible. But how do these neurons actually pass the message along, like across the gap between them?
Right, the synapse. They use chemical messengers, neurotransmitters. Tiny chemicals released into that gap, the synaptic cleft.
And they bind to the next neuron.
Yep, they bind to specific receptors, like a key in a lock, and that influences the next neuron's activity. Key examples you'll definitely come across are acetylcholine.
Important for muscles, memory.
Decreased in Alzheimer's, receptors blocked in myasthenia gravis. We'll maybe touch on that later. Then dopamine. Its loss is central to Parkinson's disease. And serotonin, involved in mood, anxiety.
Got it. Okay, moving up to the brain itself. The cerebrum, the biggest part. Lobes.
Exactly. Hemispheres, and then lobes with specific functions. Like the frontal lobe, that's your executive function, planning, goal setting. It also has the Broca area.
For speaking.
For the motor part of speech, yeah. Damage there causes expressive aphasia. You know what you want to say, but can't get the words out properly.
Okay, and other lobes.
Temporal lobe handles auditory stuff and contains the Wernicke area that's for understanding speech. Damage there leads to receptive aphasia. You hear words, but they don't make sense. And the occipital lobe, way at the back, that's all about vision.
Makes sense. What about the spinal cord? More than just a relay station.
Oh, much more. It connects the brain and body, obviously, but it's also crucial for reflexes.
Like the knee-jerk thing.
That's one type. Or pulling your hand from something hot. That's a simple reflex arc. Sensory input comes in. Synapses right in the cord with the motor neuron, and bam, muscle contracts. It happens before the signal even fully reaches your brain for conscious awareness. Figure 14.13 in your text likely shows a diagram of this direct pathway.
Quick response.
Very quick. We also talk about upper motor neurons, UMNs, which are entirely in the CNS and control fine movement, and lower motor neurons, LMNs, which are in the PNS and directly contact the muscles. Damage looks different. UMN damage often causes spasticity. LMN causes flaccid paralysis.
Okay, that distinction seems important.
Yeah.
Now, all this delicate machinery, how is it protected?
It's got layers of protection.
Yeah.
First, the bony skull and vertebrae.
Obviously.
Then the meninges, 3 membranes. The tough outer dura mater, the web-like arachnoid mater, and the delicate pia mater right on the surface of the brain and cord. And floating in the space under the arachnoid is cerebrospinal fluid, CSF. It's produced by choroid plexuses, circulates, cushions everything. It's vital. Figure 14.16 probably shows its slow path if that
Have
fin
you
gets
filtered
blocked.
that?
Exactly. That leads to hydrocephalus. And then there's the blood-brain barrier. Think of it as super tight security for the brain's capillaries. Figure 14.23 might show these tight junctions. It keeps a lot of harmful substances out.
Very selective. Does this system change as we get older? Geriatric considerations.
It does. There's a gradual, normal decrease in brain weight, some loss of myelin,
Yeah.
changes in neurotransmitter levels. Doesn't necessarily mean disease, but it can affect things like processing speed or increase vulnerability to certain issues.
Okay, good to keep in mind. Let's shift gears now to Chapter 15, Sensory and Regulatory Challenges, starting with pain, a universal experience. How does that work?
Well, pain transduction starts at specific receptors, nociceptors. When they're triggered, the signal travels along nerve fibers. There are two main types. A delta fibers, they're bigger, myelinated, fast. They carry sharp, localized pain, like if you step on a tack.
Oh, yeah.
Then there are C fibers, smaller, unmyelinated, slower. They transmit that dull, aching, poorly localized pain. Figure 15.1 in your source probably maps these pathways going up to the brain. It involves a whole pain matrix, sensory, emotional, cognitive parts, all contribute to how you actually feel pain.
But the body can fight back, right? Pain modulation.
Absolutely. We have our own built-in pain relief system, endogenous opioids, things like endorphins and kephalins. Figure 15.2 might show how these descending pathways from the brain can block pain signals lower down, like the body's own morphine.
Wow. And there are different types of pain, acute versus chronic.
A big difference. Acute pain is usually protective, signals tissue damage like a burn or an injury. It tends to resolve as healing occurs. Chronic pain is pain that lasts longer than 3 to 6 months, persists after healing should be complete. It often involves changes in the nervous system itself, making it much harder to treat.
And what about referred pain, like the heart attack example?
Ah, yes, referred pain. That's when pain is felt in an area different from the actual site of injury. The classic example, like you said, is heart attack pain felt in the left arm or jaw. Figure 15.3 probably illustrates this. It happens because sensory nerves from the heart and the arm enter the spinal cord at the same level, and the brain sort of gets confused about the origin.
Fascinating. Okay, what about temperature regulation? Keeping us not too hot, not too cold.
That's mainly the job of the hypothalamus. It acts like your body's thermostat. It balances heat production from metabolism, muscle activity, with heat loss mechanisms. Your table 15.5 likely lists things like radiation, sweating, vasodilation.
And fever, that's the hypothalamus too.
Yep, fever isn't just the body malfunctioning. It's usually a deliberate, immune-driven response. Figure 15.4 might show how chemicals released by immune cells, cytokines, tell the hypothalamus to raise the set point. So your body thinks it's too cold and works to warm up, shivering, feeling chills.
So it's trying to help fight infection.
Often, yes. But extreme temperatures are dangerous, especially for infants and the elderly. Infants lose heat, easily less insulating fat, larger surface area. The elderly often have slower circulation, less ability to shiver or sweat effectively. Makes them vulnerable to both hypo and hyperthermia.
Right. Okay, let's talk sleep. It's not just downtime, is it?
Not at all. Sleep is an active process vital for restoration, memory consolidation. It cycles through two main types. Non-REM sleep makes up most of the night, about 75–80%. Brain activity slows down, body repairs itself, growth hormone is released.
And REM.
REM sleep, rapid eye movement sleep, about 20–25%. That's paradoxical sleep. Your brain is highly active, almost like being awake. That's when most vivid dreaming happens, and is crucial for memory processing. We also lose temperature regulation during REM.
Interesting. And sleep disorders, like apnea.
Yep, obstructive sleep apnea syndrome, OSAS, is very common. The airway collapses or gets blocked during sleep, leading to loud snoring, pauses in breathing, and then gasping. It disrupts sleep quality badly.
Okay. And quickly touching on the special senses. Any key issues to highlight for vision or hearing?
For vision, cataracts are a big one, clouding of the lens, a major cause of blindness worldwide, and glaucoma, increased pressure inside the eye, damaging the optic nerve. For hearing, your book probably shows the ear structures in figures 15.11n and 15.1 sound waves vibrating the little bones, the ossicles, in the middle ear.
Malleus, emphyseous, stapes.
Right, transmitting vibrations to the cochlea in the inner ear. Common problems include otitis media, middle ear infections, especially in kids, and in older adults, presbycusis, age-related sensorineural hearing loss problems in the inner ear or nerve pathways.
Got it. All right, let's move into Chapter 16. Complex brain dysfunctions, things like awareness, thought, movement. How do we assess brain function clinically?
Level of consciousness is probably the single most critical indicator. We assess it on a spectrum, from alert and oriented down through confusion, lethargy, stupor, to coma. Clinicians look for specific patterns.
Like what?
Breathing patterns, for one. Cheyne-Stokes breathing, which figures 16.1 might illustrate, is that weird cycle of fast breathing, then apnea. Pupillary reactions are the equal, reacted to light. Figure 16.2 might show abnormal pupils, like fixed and dilated, indicating serious brainstem issues. Oculomotor responses, like the doll's eyes maneuver, figure 16.3, and motor responses, purposeful movement, versus abnormal posturing, like decorticate or decerebrate posture, which figure 16.6 likely depicts. These signs point to the location and severity of dysfunction.
And there's a difference between brain death and cerebral death.
Yes, crucial distinction. Brain death is irreversible cessation of function of the entire brain, including the brainstem. The body can't maintain homeostasis. Cerebral death means irreversible damage to the cerebrum, loss of consciousness, but the brainstem might still function, maintaining breathing and circulation.
Okay. What about problems with thinking, memory, attention?
We see amnesia. Difficulty with memory retrograde is loss of past memories. Anterograde is inability to form new ones. ADHD, attention deficit hyperactivity disorder, affects attention and executive function, often continuing to adulthood. Then there's aphasia, language impairment. We mentioned Broca's expressive and Wernicke's receptive earlier.
And what if someone suddenly becomes confused? What does that signify?
That often points to acute confusional states, also called delirium. It's usually a transient disorder, often caused by things like infection, metabolic problems, or medications. It develops fairly quickly, fluctuates, and affects attention and awareness. It's distinct from dementia. Your table 16-point Venn probably contrasts them well.
Let's talk more about dementia then, a progressive decline.
Yes, dementia is a progressive failure of many cerebral functions: orientation, memory, language, judgment. The most common type by far is Alzheimer's disease, AD.
And that has specific changes in the brain.
Very specific, yes. Figure 16.8 in your text likely illustrates the key neuropathologies. Neuritic plaques, which are clumps of amyloid beta protein outside the neurons, and neurofibrillary tangles, twisted tau protein inside the neurons. These disrupt communication, cause neuron death, particularly affecting areas crucial for memory, leading to that progressive cognitive decline. Loss of acetylcholine is also a major factor.
Devastating. Okay, switching gears slightly. Seizure disorders. The electrical storms.
Good analogy. A seizure is caused by a sudden, abnormal, excessive electrical discharge from neurons in the brain. Epilepsy is the condition of having recurrent, unprovoked seizures.
What happens during one?
The abnormal electrical activity spreads. Often leads to a tonic phase, muscles contract stiffly, followed by a clonic phase, alternating contraction and relaxation, the convulsions. During this, the brain uses a massive amount of oxygen, potentially leading to hypoxia.
Scary stuff. What about pressure inside the head? Increased intracranial pressure, ICP.
Very dangerous. Normal ICP is kept low. If it increases due to swelling, edema, bleeding, hematoma, or a tumor, it can compress brain tissue. The worst outcome is brain herniation, where part of the brain is squeezed across structures within the skull, cutting off blood supply. That's often fatal.
And hydrocephalus is related?
Yes, hydrocephalus is one cause of increased ICP. It's an excess accumulation of that cerebrospinal fluid we talked about, either because too much is made, it's not reabsorbed properly, or its circulation is blocked. Often needs a shunt to drain the excess fluid.
Okay. And finally in this chapter, controlling movement. Neuromotor function, like Parkinson's.
Parkinson's disease, PD, is a classic example of a neuromotor disorder. The core problem, as figure 16.16 might show, is the degeneration of dopamine-producing neurons in a part of the brain called the substantia nigra.
So less dopamine.
Right. Dopamine is inhibitory. Its loss leads to an imbalance with excitatory neurotransmitters like acetylcholine. This causes the characteristic tremor, muscle rigidity, and bradykinesia slowness of movement.
And ALS.
Amyotrophic lateral sclerosis, ALS, Lou Gehrig's disease, that's a progressive destruction of both upper and lower motor neurons, leading to widespread muscle weakness and paralysis, a truly devastating disease.
Okay, moving to chapter 17. Trauma, degeneration, and infection. Big topics. Let's start with traumatic brain injury, TBI.
TBI is complex. There's the primary injury, the damage done at the moment of impact. Could be focal, like a bruise, or diffuse, like widespread axonal shearing.
And secondary injury.
That's the cascade of problems after the initial hit. Inflammation, swelling, increased intracranial pressure, ischemia, often causing more damage than the primary injury itself. Severity is often assessed using the Glasgow Coma Scale, GCS, which table 17.2 probably details. We also see different types of bleeding, like epidural hematomas, often arterial, very fast, needing urgent surgery.
What about spinal cord injury, SCI?
Similar concept, primary mechanical damage, followed by secondary injury processes like hemorrhage and swelling. Immediately after injury, there's often spinal shock, temporary loss of all reflex function below the level of injury, flaccid paralysis, loss of sensation.
And that resolves.
Usually, yes. But then, particularly in injuries at T6 or above, a dangerous condition called autonomic hyperreflexia can emerge.
It's sad.
It's an uncontrolled, massive sympathetic nervous system discharge in response to stimuli below the injury level, often a full bladder or bowel. Figure 17.7 might diagram this. Since the brain can't modulate the response, you get sudden severe hypertension, headache, sweating above the lesion, but often bradycardia. It's a medical emergency.
Wow, okay. What about more common back issues, degenerative spinal disorders?
Things like degenerative disc disease, where the intervertebral discs wear down, lose hydration. This can lead to a herniated disc, where the soft center pushes out and can compress spinal nerves, causing pain, numbness, weakness, often called radiculopathy or sciatica, if it affects the sciatic nerve.
Ouch. Let's talk stroke. What's the difference between types?
A stroke is essentially brain damage due to interrupted blood flow. Most common is ischemic stroke, where a blood vessel is blocked by a clot, thrombus, or embolus.
Like a blockage in the plumbing.
Exactly. Then there's hemorrhagic stroke, which is bleeding into the brain tissue itself, often from chronic high blood pressure, rupturing a vessel, or from a ruptured aneurysm.
And a TIA.
A transient ischemic attack, TIA, is like a mini-stroke. Symptoms are temporary, resolve completely, usually within minutes to hours, but it's a major warning sign for a future full stroke.
Okay. Headaches, migraine versus cluster.
Migraine is usually an episodic, often throbbing headache, frequently one-sided, sometimes preceded by an aura, often associated with nausea, light sensitivity. Cluster headaches are different, extremely severe, stabbing pain, usually around one eye, occurring in groups or clusters over weeks or months, often with autonomic signs like tearing or a stuffy nose on that side.
Nasty. Infections. Meningitis.
Bacterial meningitis is a serious infection of the meninges. Key signs are severe headache, fever, stiff neck, neutral rigidity. Some types, like meningococcal meningitis, can cause a petechial rash and be rapidly fatal or lead to limb loss. Needs urgent antibiotics.
And multiple sclerosis, MS. That's not an infection, right?
Correct. MS is an autoimmune disease. The body's own immune system attacks the myelin sheath in the central nervous system, brain, and spinal cord. Figure 17.13 probably shows how this creates plaques or lesions, disrupting nerve signal transmission and causing a huge variety of neurological symptoms that often wax and wane.
Okay. What about the peripheral nerves? Myasthenia gravis, MG.
MG. Another autoimmune condition, but this one affects the neuromuscular junction, the communication point between nerve and muscle. Antibodies block or destroy acetylcholine receptors on the muscle side.
So the signal doesn't get through properly?
Exactly. Leads to characteristic muscle weakness and fatigability that worsens with activity and improves with rest.
And finally, for this chapter, brain and spinal cord tumors.
They can be primary, arising from brain cells themselves, like gliomas, such as astrocytoma or the very aggressive glioblastoma. Or they can be metastatic, meaning cancer spread to the brain from elsewhere, like lung or breast cancer. Metastatic tumors are actually more common than primary ones.
Right. Okay, last chapter, chapter 18, pediatric neurology. How does development start?
It starts very early in gestation with neural tube formation. That tube becomes the brain and spinal cord. After birth, the skull isn't fully fused. Those fontanelles, or soft spots, allow the brain to grow rapidly. We also see neonatal reflexes like sucking or grasping, which should gradually disappear as the cortex matures. Their presence or absence tells us about neurological development.
What happens if that neural tube doesn't close properly? Neural tube defects, NTDs.
That's a major category of birth defects. Spina bifida is the most common. The most severe form is myelomeningocele, where, as figure 18.4 probably depicts, a sac containing meninges, CSF, and part of the spinal cord itself protrudes through a gap in the vertebrae, usually in the lower back.
And that causes problems.
Oh, absolutely. Often causes paralysis below the level of the lesion, bowel bladder dysfunction, and frequently associated hydrocephalus. The functional impact really depends on how high up the defect is.
Okay. What about cerebral palsy, CP?
CP isn't one specific thing, but rather a group of disorders affecting movement, muscle tone, and posture. It's caused by damage or abnormal development in the immature brain, usually before, during, or shortly after birth. The most common type is spastic CP, with increased muscle tone due to damage to motor pathways.
And sometimes metabolism affects the brain. Inherited metabolic disorders.
Yes. Phenylketonuria, or PKU, is a key example. It's an inherited inability to break down the amino acid phenylalanine. If it builds up, as figure 18.8 might show, it becomes toxic to the developing brain, causing severe intellectual disability.
But we screen for that.
Yes, newborn screening is critical. If caught early, a special low phenylalanine diet can allow for essentially normal brain development. It's a real success story of newborn screening.
Great. And lastly, childhood seizures.
Febrile seizures are quite common in young children, usually under 5. They're seizures triggered by a high fever. While frightening for parents, they're typically benign and don't cause long-term problems or epilepsy.
Wow. Okay, that was a whirlwind tour through Unit 4, the neurologic system. We covered the absolute basics in Chapter 14, CNS, PNS, neurons, neurotransmitters, brain structure protection. Then Chapter 15 hit sensory and regulation pain, temperature, sleep. Chapter 16 tackled complex dysfunctions, consciousness, cognition, dementia like Alzheimer's, seizures, ICP, movement disorders like Parkinson's.
And then Chapter 17 dealt with major threats, TBI, SCI, including that tricky autonomic hyperreflexia, stroke, infections like meningitis, autoimmune conditions like MS and MG. And finally, Chapter 18 focused on pediatric development, neural tube defects like myelomeningocele, CP, and PKU.
It really highlights the incredible intricacy, doesn't it?
It absolutely does. Connecting this all together, you really see how understanding these pathways, these mechanisms, both normal and abnormal, is fundamental. It underpins so much of clinical practice, but also just appreciating the sheer complexity and vulnerability of how we function, how we experience the world.
So, the final thought for you, our listener. As you grapple with this complex system, consider how this knowledge changes your perspective. Whether you're heading into healthcare or just trying to understand yourself and others better, how does knowing about the brain's wiring, its potential pitfalls, and its remarkable resilience shape your view of human experience? What does it mean to understand the very organ that allows us to understand?
A lot to think about.
Definitely. On behalf of the Deep Dive team, thank you so much for joining us for this exploration of the neurologic system. Keep exploring, keep questioning, and keep learning.